these are still lethal weapons. Let's pivot to the third critical area, standardizing safety. Because without that, these therapies can't move beyond a handful of elite cancer centers.
That's the reality. CAR-T toxicity, CRS, and CRS can be severe, even fatal. The need for specialized critical care and expert staff has been a major constraint, especially in rapidly expanding markets like China.
To tackle this, a major consensus was developed by multiple leading Chinese institutions, giving refined, standardized guidelines for managing these toxicities, specifically in B-cell non-Hodgkin lymphoma.
Yes, and they focused heavily on refining the classification of cytokine release syndrome. They introduced classification based not just on time of onset, acute, late, chronic, but also on location. Systemic versus a phenomenon they call local CRS, or LCRS.
Local CRS, that sounds like a key distinction.
It is. LCRS is seen a lot in patients with a high tumor burden, and it shows up right where the lymphoma is most active. So instead of just a systemic fever, LCRS is redness, swelling, effusion right at the lesion site.
And if those lesions are in, say, the gut or near an airway, that localized inflammation becomes incredibly dangerous.
Incredibly. The swelling can lead to perforation or bleeding. This meant they needed very specific management protocols tailored to the location.
Can you give us an example? How do you manage LCRS differently than systemic CRS?
Well, take the GI tract. If you suspect gastrointestinal involvement, the consensus recommends gut purging and oral antibiotics before the SAR-T infusion even starts.
So it's proactive.
It's proactive. The logic is you prevent intestinal flora from migrating and fueling a much larger systemic CRS response once that localized tissue damage begins.
That's incredibly detailed, proactive care. What about a severe case like in the neck area?
For severe LCRS in sensitive organs, like a huge neck mass swelling near the airway, they advise using anti-TNF-alpha agents. And critically, they recommend local interventions, like a tracheotomy, to manage the compression before it becomes a respiratory crisis.
That really highlights the stakes. Okay, moving to neurotoxicity, CRES. What's the standard path there?
The incidence is somewhere between 20 and 64%, and its severity is tied to high cytokine levels and tumor burden. The consensus confirms that steroids are the absolute cornerstone of treatment for CRES.
Right.
They're highly effective at calming that inflammatory storm in the brain.
And this leads to that critical distinction. Tocilizumab, the drug famous for treating systemic CRS, is not the go-to for CRS alone.
Exactly. The experts are explicit. Tocilizumab is not recommended for CRS unless the patient also has significant systemic CRS. For CRES, the focus is steroids. And they even recommend prophylaxis, giving high-risk patients levetiracetam to help prevent seizures.
Finally, we have to cover the long-term expected toxicities, starting with B-cell aplasia, the on-target, off-tumor effect.
This is an expected consequence. You kill the B-cell cancer, you kill the healthy B-cells too. This leads to hypogammaglobulinemia, so the patient can't fight certain infections.
So how do you manage that?
The guidelines standardize it. Prophylactic monthly intravenous immunoglobulin or IVIU until the B cells recover, or for at least 6 months.